IC regulation, I teach burns, and I teach advocacy as well. My background is ER trauma, so that's why I do, oh, you like trauma? Yeah, okay. So, I worked in the ER Charity Hospital, so, and every other place, every other ER here, and a lot in California, Hawaii, and I did a lot of traveling. So, I'm pretty doggone well-versed in trauma. So what we're going to do today is, I already gave you a recording. I gave you the explanation on Canvas as to why I do things the way I do. And it seems to have worked out well in the past. You usually are not guessing what content you're responsible for that I give you. The knowledge that you're going to get on that video and your, what am I calling? I'm having a brain fart. That thing, yes, the algorithm, sorry, as well as the journal article, the 2018 Critical Care Journal article, it supplements what I have in here. I don't ask you to read 50,000 things, okay? You got a reading of, you're listening to the video, you're reading that article, and you've got that algorithm. And I think I put the ICO. Did all of y'all get the PDF of the Critical Care book? Somebody, no. But in general, the Critical Care book that y'all are supposed to have, I found from a former student the PDF of it. But I can't disseminate that to you because I don't know if I'm doing any kind of publishing copyright infringement. So I sent it to a student and said, and they were supposed to put it, so if you're on any kind of chat, whatever, you can get it from them. And it's PDF, so it's wonderful. You don't have to print it or anything. And again, I don't have you doing a lot of reading off of the Critical Care book, but others do. And if you can get it for free, hey, you know. So if you're not sure where it came from, I'll ask my student again, because she said she was going to disseminate it somehow or another. And if that didn't get around to you, then by all means. If it's a free book on PDF, take it. All right, so anyway, so what I like to do is I give you your recording. And I know you're going to have test 1 tomorrow, so you probably didn't, if you listened to it, it went in one ear and out the other because you're trying not to fill your brain with too much information, which is not possible, okay, just to let y'all know. But at any rate, you have your recording that you will listen to, that you will take your notes on. I am doing a case study with you today to apply and analyze the knowledge you got from the video and the reading. It worked well this morning. You may not be able to answer every single question, but it's giving you a little bit of a hint of how you're going to tackle this content, all right? I'm a process-driven individual. I'm linear. I'm a step-by-step, so it's very, or I've been told I'm very organized, so it should not, I'm not all over the place with y'all. So what we're going to do first is I have a little matching exercise that I want y'all to do. You need to take out a sheet of paper. I'm doing it exactly the way I did it this morning for Team 3. And this is a matching exercise. This is a matching exercise on the different types of brain injuries and some of the classic signs and symptoms. So what I need you to do is I want you to write numbers 1 through 9, and I'm going to give you the different brain traumas, and then I want you to write each one of them down. All right, number 1 is concussion, and it follows my video. Number 2 is a cerebral contusion. Number 3 is a cerebral laceration. Wait, I'm sorry, my bad. I'm sorry. Well, I can't see. All right, 1 is a concussion, my bad. 2 is basilar skull fracture. 3 is cerebral contusion, and 4 is cerebral laceration. I apologize.
What did you say number 2 and 3?
Sure, baby. 1 is concussion. 2 is basilar skull fracture. 3 is cerebral contusion. And 4 is cerebral laceration. Okay, so number 5 is epidural hematoma. And 6 is subdural hematoma. 7 is subarachnoid hemorrhage. 8 is brain herniation. Who the hell is that? Is that somebody in a home? Go check it out, Sheriff. Yeah, the person who sits in class has to be the runner for the lecture. All right, and number 9, diffuse axonal injury.
Sorry, number 9 is axonal.
Diffuse
Oh,
axonal injury. Okay. Now, I am going to read the classic cue, because we're going from signs and symbols to cues, and you're going to tell me which one it is. Now, if one of y'all is like, already did this, and don't blurt out the answers, hang tight, and then we can all say the answers together, okay? Give other people, in other words, give other people a chance to figure it out before you blurt it out. All right, so the first clue or cue is patient says this is the worst headache of my life. So go look at all 9 of these injuries, and if you don't know, guess. Don't say anything yet. All right, anybody got any idea? Subarachnoid hemorrhage. All right, so write that down next to subarachnoid hemorrhage. All right, next clue or cue is the patient is unconscious, then has a period of lucidity, which means they're conscious, and then they have a rapid neurological decline. Is that person across the hall or Nelsia? Maybe we all need spongy earplugs in here. All right, so what do y'all think about this unconscious period, then they're lucid, and then they, boom, go down? What do you think? And that is Ding, 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 ding. Give the man a prize. Epidural hematoma. All right. The next one is extreme brain tissue swelling causing visceral or decorticate posturing. All right, Jonathan, bam, what do you think it is? Just look at the words and see if you can figure it out, because that sounds pretty doggone bad, right?
I would say, is it two?
Which one?
Basilar skull fracture?
Negative, sir, sorry.
Okay.
Is that Sasha? Is there a Sasha? So what do you think, Sasha? When you lift something, what?
Contusion? The cerebral contusion?
No. Okay. When you lift something really heavy, and this happens often in brain herniation. And when you listen to my Academy Award-winning video, you too will understand why, and go look at the pictures to see why. That's those, when you have brain herniation, those are your local candidates. Those are the people that they declare brain dead, and they're organ donors, because you don't come back from that, okay? All right, so the next one is periorbital ecchymosis, or ecchymosis behind the ear, and the patient has a high risk for developing meningitis due to a CSF leak.
Can you repeat that one?
Sure. Periorbital ecchymosis, or ecchymosis behind the ear, and it would be helpful if y'all remembered what ecchymosis was. High risk for meningitis due to a cerebrospinal fluid leak.
Is it two?
What,
Basilar?
and what is that called?
Basilar skull fracture?
Basilar skull fracture. Yes. Very good. All right, next one. Now listen to this, and if you listen to the descriptions, you can probably figure it out. Bruising of brain tissue caused by a blow to the head. Wait, what?
The cerebral contusion.
Right, because what is a contusion?
A bruise.
A bruise. Okay, there you go. All right. So the next one is the shearing of axons caused by rapid acceleration or deceleration of brain tissue against the hard skull.
It's the last one.
Do what?
It's the last one.
Diffuse axonal injury.
Yep. Y'all put that, you heard the word axons, yeah. Remember going back to, what was it, AMP1, where you learned about the axons and the dendrites, and that's how the neural pathways and this, that, and the other. Once those axons snap, they don't regenerate. They're gone. So people who have diffuse axonal injuries also have limited mobility and movement that doesn't come back because those axons sending those signals to lift your left hand. If that's where busted, that doesn't come back because they don't regenerate, okay? All right, so the next one. Penetrating injury to the skull causing a tear to the brain tissue.
That's the laceration.
Cerebral laceration, there you go. So that's your steak knife to the skull. How do I know that? Because I've seen somebody come in with a steak knife because he was stepping out on his wife at the Dookie Chase with somebody else. She figured it out, walked in there and payat him in the head. Yeah. I've seen a lot of things. They paid me to see this. It was great. I loved it. All right, so the next one is these symptoms include nausea, vomiting, or confusion. Now you only got 2 choices left. Concussion, absolutely. You need to learn about concussions because, first of all, they're very common. Anything you do any kind of initial head trauma could be a concussion. Your kids play some kind of sports, or even your babies or your grandbaby, the big bobblehead, boom, they fall and go boom. Luckily, they bounce really good. But concussions are very, very common. So I also try to give you public service announcements. You're welcome. So you need to pay attention to that. Symptoms usually last about, what they say, up to, I think on my video,
3 months.
it says like 2,
You said under 3 months.
yeah, and they should go away. Now, you also got to figure out, because like confusion or something like that, if mama was confused before they hit the head and got a concussion, then that's not going away. But you got to pay attention if you know the baseline of the person and you send them home with those instructions. Pay attention to make sure they're not getting super confused or anything like that. If they do, come back or whatever, you kind of got to know what your family member was before that, whether their cognitive level, to know if they're getting better. And the hard thing about older geriatric clients is, and I've seen this happen so many times, the onset of dementia is like, boom. Mama could be right as rain one day, and then something, first you're thinking it's a UTI, because that's common confusion in older people, but they take them to the doctor, the UA is negative. That's just, it's bizarre. So that's kind of hard to do. But anyway, so concussions you need to know about. You need to know the basic stuff about these different injuries, because if you can determine the level of trauma from each one of them, then that can give you an idea of how extensive their treatment's going to be. Obviously, the more severe the injury, the higher order of treatment they're going to receive. I'm not going to go crazy into this, but the nice thing about having this at this time, right before test 1, for y'all that were brave enough to come on out here, they're going on I'm going to talk about them going on events. I'm talking about a lot of stuff that you're being tested on tomorrow, so it's not like you got to relearn it. That's the good thing. And I am good friends with Ms. Sanders, who teaches you IC regulation on on level 3. So I talked to her years ago to say, hey, Sheena, I know you teach them this. I teach them this in 4th level. Let's see what they know, what I can expect them to already know when they come in to me. Hydrocephalus, an ICP caused by whatever, don't matter what causes it, increased ICP is increased ICP. You're going to treat them, but y'all learned in hydrocephalus in kids. I'm just teaching you the extensive stuff that they're going to do in adults. Okay? It's not all inclusive because we wouldn't be teaching it if it was a total repeat. This whole course is acute life-threatening. So I'm teaching you about, because hydrocephalus can historically be managed, but traumatic brain injuries are a big cause of either disability and death. So that's why I'm teaching it in level 4. So now what I'm going to do is I'm going to I'll catch the roll later. I'm not even worried about doing it now. It's an act of Congress to get into. All right, so my case study that I developed kind of goes along with your video and all of that. So I'm using this to double check just to make sure that I'm covering what I need to cover. I use it as a guide. But this is your case study. The case study's not coming up here. I'm telling you the case study, and then as we go over the case study, I'm going to be looking at some of these slides to make sure I'm hitting topics for you guys. So what I need you to do, you can do it on that same sheet of paper. I'm going to read out my case study that I just developed at 5 o'clock this morning because I got a wild hair to get up and say, oh, let me throw together something new. So y'all all get report when you go to clinical, right? You all have to learn to write down pertinent information and report, correct? This is what I want you to do. I'm going to read off this case study to you, and then you're going to write down what you feel is pertinent information that you need to have so that as we're going along in this case study, you can refer back to it. All right? Everybody got a sheet of paper to start writing this stuff down? Okay. All right. Ms. Smith is a 58-year-old white female with a history of hypertension and non-insulin dependent diabetes. She also has a 40-year smoking history. She was found at 6:30 in the morning, laying on the ground, unresponsive, in her backyard. She was found by her mother. After calling and she was breathing. But after calling 911, her mother began to do chest compressions, at which time Ms. Smith aroused and said, "What are you doing?" EMS arrived. They assessed Ms. Smith. Her Glasgow Coma Scale score was 14. And it was 14 because she was confused about why she woke up on the ground. Okay, so she was confused about the events of whatever occurred. Her pupils were equal, reactive to light and accommodation, and the sizes were 4 bilaterally. They did a CBG on her, and it was 68. EMS assessed. Tear it up, girl. And come sign this roll while you're at it.
Yes, ma'am.
All right. So EMS, where was I? All right, Perla bilateral. CBG 68, no visible trauma. So EMS applied a cervical collar, a rigid cervical collar, not one of them spongy little things you see people driving around wearing. We're doing a case study. Are y'all recording any of this? Y'all need to ask me, because I didn't want to share this until everybody had it. You can record it, but I promise, do not share this until, I will post it after everybody has, because I've still got to teach this 2 more times, okay? Y'all just gotta ask people, because there's a reason why, all right? So anyway, where was I? Oh, the cervical collar was applied, and she was secured onto a long spine board that was on the stretcher, because you know EMS always brings a stretcher with them, and when they heard that they were found down, they bring the spine board and a C-collar, because that's standard protocol, okay? So they brought her to the ambulance, put her in the back of the ambulance, they put her on a cardiac monitor. She was in normal sinus rhythm. And they put an 18 gauge IV in her left AC, antecubital. And they hung a bag of normal saline, and it was going at a to keep open rate, because they don't have pumps, so I can't give you a rate number, but it was just, basically it's roughly like 50 milliliters an hour, roughly, okay? They put, her O2 sat on room air was 98%, but they put 2 liters of nasal cannula on her anyway. And her blood pressure was 180/78. Heart rate was 88. We already said she was in a normal sinus rhythm on the monitor. She was breathing at a rate of 20. And the little strip on her head, because they don't have little temperature strips, that may or may not be right, clocked her at 98.4 for a temperature. Do I need to repeat anything that y'all need to get written down that you didn't catch? Any of the pertinent information? Y'all got it? Got a picture in your head? Okay, good. So, they're on their way to the hospital. Well, lo and behold, Miss Smith becomes unresponsive. But she's still breathing. And she's still got peripheral pulses. So, the paramedic that's in the back of the truck, riding her to the hospital, says, ruh-roh, they intubated her. And as they're rolling her into the ER, she's intubated, and they're ventilating her with the bag valve mask. And it's 100% O2 hooked up to the tank and all that good stuff, okay? All right. So you got a visual of what's going on with the lady. All right, good. So now, why, is that a video? Good job. Okay. Why did EMS intubate Miss Smith when she became unresponsive, but she was still breathing? Why? Anybody know?
GCS was.
Well, I didn't give you a repeat GPS, but it did, just by her becoming unresponsive, her GCS did go down. Now, I know that you might have heard in prior lectures, if they have a Glasgow Coma Scale score or 8 or below, they're automatically intubated. However, don't think that just because they have they can have a GCS higher than that and still be prophylactically intubated because their injury is such that they could lose consciousness or their whole state could deteriorate at the drop of a hat. So there are times where they could be a 15, come in as a 15, but because of their injuries, they will prophylactically do what they call rapid sequence induction, where they'll give them paralytics, sedatives and paralytics. And once you get a paralytic, it paralyzes everything, including the diaphragm, so they've got to intubate you. So just keep that in mind. And y'all can chime in and ask any questions or any clarification at any time. Just feel free to chime in, okay? All right, so now I'll give you her picture. She's still in the trauma recovery room, but now she's intubated and they're bagging her. So who are they going to call to help them out with this? What part of the interdisciplinary team are they going to call? Huh? Respiratory? Did you say yes, that why?
What you saying?
They need what? Yeah, why do we need respiratory therapy? What are they going to roll with them? A ventilator, because now all they're doing is manually bagging this person, and who's got time for that, okay? So respiratory will be, and I'm talking about now historically in a level 1 trauma center, respiratory is coming down already. But that doesn't mean that you can't be in little Podunk, Port Sulphur, Louisiana in a Band-Aid station, the only nurse on, in the ER, and your doctor is a podiatrist, and they got a respiratory therapist somewhere around there. So it's conceivable you will be bagging for a while. So keep that in mind when y'all decide to start working agency shifts at these outlying places. Be careful what you're going into, because you don't know, okay? Especially if you're ER. So yes, respiratory is going to need to be called to get them hooked up to a vent. All right. However, the patient was intubated by EMS before they got there. Now, I have a lot of friends that were in EMS for years. Okay, but you try intubating somebody who's laying there straight on a non-movable thing, and it's still hard. But bouncing in the back of an ambulance that's going, 65 miles an hour or whatever down with the lights and sirens and all of that, and transporting them, and then when they get off, we got to take them from that EMS stretcher and transport them to the bed. That ET tube that they put in, y'all learned about ET tubes already, right? You learned that they go in, they blow up the balloon to make sure they don't come out again. They're supposed to secure them. But you always check what? Placement. And how do we check placement to see that it's in the right spot? So, wait, what did you say? Do what?
Like you want to make sure it's not like the right bronchus.
And what's a quick and easy way to figure that out? You auscultate over the left to make sure you hear breath sounds, because if you hear them on the left, that they haven't done a right mainstem bronchus intubation, which can be done under bizarre conditions, okay? Seen it happen all the time. The tube gets dislodged, no matter whether it's, blown up or not. Because that little, when you get to Ms. Garrettson, or who did that lecture? Garrettson? Did she bring you the ET tube and show you a little? Okay, good. I figured she would. So, anyway, always check placement by auscultation. And then they're gonna get a chest X-ray just to make sure as well, okay? But later, we're worried about taking care of them and getting them resuscitated right now, okay? So we auscultated breath sounds, right? All right. So there is everything's a process that we do in nursing. That's the beauty of nursing. Once you now, it takes you a hot minute to learn the process, but once you do, it don't change. When these algorithms, every once in a while, the algorithms will change with American Heart and all of that stuff. And with new research coming out, the algorithm that I gave you, the maintenance of a patient with a traumatic brain injury, that has evolved over time based on research. And I teach y'all research too, so all of my stuff is kind of tied together, luckily. So things have evolved over time, but right now they have a mnemonic, and you already learned it with Ms. Garrettson, and it's one of those bundles. Same bundle here, okay? So you don't have to relearn it. You already learned it. You'll apply it, though, with my content, because it doesn't change. So we've got, I want to make sure I'm covering all of this. So the patient, we've already established, we've listened, we've got a patent airway because we already know that we've listened, and that tube's where it's supposed to be. So that is letter what? And now, what's some other B's that you're going to look at? You understand that you got breath sounds, but what else do you want to look at when you're looking and you're going in your head to toe assessment? Even though they're on a vent, what do you want to make sure that you're still visualizing for a patient, especially if they've got any kind of trauma? What else about breathing? Chest, equal rise and fall of the chest. Y'all haven't had your chest trauma lecture yet. Ms. Dickerson's going to do that for you with her little stick man. But, yes, you want to see equal rise and fall of the chest. Trauma is tricky. You can have something that's a visible trauma, but you don't know the other trauma you can't see. Just like a gunshot wound to the buttocks can be fatal because it goes in and that bullet bounces all around. I've had patients come in with that and they tore up all their insides and had to go straight to surgery before they bled out. So ain't nothing funny about getting shot in the butt because it can kill you, okay? I don't care how big your booty is. All right, so we've got breathing. We want to make sure they have equal rise and fall of the chest. All right, now, we got airway A, B done. What's next? All right, so what about this patient that we've heard already or that we need to assess that's related to circulation? Y'all, either I'm going deaf or y'all are mumbling. Even if it's wrong, no judgment here. Y'all, I know y'all don't know this stuff yet, but I still want to hear what you're saying because it might be right. What did you say with circulation?
Peripheral pulses.
Peripheral pulses, yes, that's good. Blood pressure is another one. You got your. There's three things you're going to assess on your hands and on your feet. Cap two are cardiac, one is neuro. Cap refill, bilateral radial pulses, and can you squeeze? Same thing on feet. Remember that? Because if you don't do an assessment the same way every time for the rest of your nursing career, you're going to miss something. And you're going to miss something big. So that's why learn your process for your head to toe, anterior, posterior, and commit it to memory. So we've got, and what else that we're going to hook them up to that's related to circulation besides the blood pressure thing? Heart monitor, absolutely. And while we're hooking them up to the heart monitor and we're touching their body, what else can we assess when it comes to circulation? Skin temperature. I'm looking at them. I'm looking at their color. Exactly. You're going to find that as a nurse, you're going to start killing a bunch of birds with one stone with these short, quick, 2-minute head-to-toe, anterior, posterior assessments. You're going to be able to walk into a patient's room, no matter where you're working, and say, do I see a rise and fall of the chest? That's a good thing. you're going to learn to see it even when they're sleeping and they're breathing shallow. And then you're going to start assessing all these. It's just going to be automatic. Like, you know when your kid's sick or your animal's sick, even if you don't see them, you feel that. Same thing. And them gut instincts, that's nursing, y'all. That's nursing. And you don't forget it, okay, once you learn it. All right, so we got all of our C's pretty much taken care of. Oh, no, we didn't, because in report, what did I tell y'all that was related to assessment, that they came in already having, the EMS already did it. That's related to circulation. The IV. You have to check, especially, they're putting the IV in the back of a truck, right? Okay, I've done it before, and it ain't easy. Okay, so, and when they bring you in, they take that bag, throw it in between their legs, okay, and roll them on in. Then you got to pick it up, and you got to hang it up. And if it was at a TKO rate, you got to open it up to see, and you got to check and see if it's patent. And trauma patients warrant 2 large bore IVs. So, you got your 18 in your left arm. You're checking to see, you open up your roller to see if it's still going, and you're looking to see that it hasn't infiltrated. And then you're going to start another one, okay? Because they may go to surgery, and that's standard protocol on anybody going to surgery for trauma, 2 large bore IVs, okay? All right, so now let's talk about what's the next letter. We covered A, B, and C. What's next? And what does D stand for? No, not in this case, but it's close. Neurological deficits, exactly, okay? So, how do we do a neuro, starting in a head-to-toe fashion on an intubated patient? How are you going to check, what are you going to check, even if they're intubated and sedated? It doesn't deviate. You're still going to go from head to toe. What's the first thing you're going to check? Did you say their eyes? Good. What about their eyes?
You're going to check the pupils.
You need to check the pupils. Now, they already said before she came in, EMS gave you in report, they were forward and brisk before she lost consciousness. So we know she was neurologically intact with her pupils beforehand. But we've also sedated them to intubate them, and we're keeping them sedated because people don't tolerate being intubated and awake well. I've seen it, but in this type of patient, no. So we're usually sedating them with what? Huh? So Ms. Garrettson talked to y'all about Precedex. Could be, most of the time I see propofol used, just like when you're going to get your conscious sedation, to get your cold, well, y'all aren't probably young too, but whatever you're going to do, you're getting the Michael Jackson drug, and it's so nice because you wake up and you're like, loved it. But anyway, propofol might be what they use in the units. I do know that they still use propofol a lot as well. Whatever sedative of choice your facility likes to go with, what does that do to pupillary responses, though? It'll make it sluggish. It'll make it, and if they got narcotic analgesics, because just because you knocked out don't mean you're in pain. So they probably got narcotic analgesics, and what do they do to your pupils? They constrict, right? They'll be pinpoint. But when you learn to be a good, seasoned neuro or ER or ICU nurse, you're going to know how to be able to check pupillary response and see, even if they're pinpoint, you will see them respond. Okay, not a lot, they don't have too much more to squeeze, but they will, okay? So we've got the pupils, we're looking for responsiveness there, and these are hourly checks. You're doing your hourly neuro checks. She already talked to y'all, and I don't talk to y'all too much, I don't bring it up because did she talk to y'all about the levels of sedation?
Yes.
Yeah, okay, so your RAS, and we do that too, we look at that as well. Because they like to use propofol specifically for neuro. I don't know that much about the Precedex, but I do know that propofol has a very short half-life to it. So you can put them on a propofol drip, and then when neurosurgery wants to come in and assess their neurological status, you can turn it off, and within 5 minutes, I wouldn't say they're awake, but they're definitely more arousable than they were when they had it on them. So that way neurosurgery can do their assessments, and then you put them back on it, and boop, they're knocked out again. I don't know if, because I'm not as familiar with the Precedex, I'd have to Google that and look it up.
It has reversal, I believe.
Huh?
Yeah, Precedex has reversal.
You have to do a reverse? Oh, no, we ain't got time for that. No. We need to turn it off and get them to, I mean, there are reversal agents for that, just like Narcan. We ain't got time for that, no. So, anyway, so we got our neuro deficits. Let me see if there's anything else. No. All right. When you're doing, so we did our head assessment, we did our pupils. You're looking for any visible trauma. There was none on her, okay? So everything's internal, which is really hard to deal with because you can't see it, okay? Now, the lady's got a C-collar on already, right? Because anytime you have a loss of consciousness, you're found down like that, they assume you fell and hit your head. Because nobody just lays down, oh, I'm going to faint, and lays down and then faints, okay? So, but you can faint, hit the ground, and not have visible trauma either. But so they're going to put the C-collar on you because anytime anybody has a suspected head injury, we also say that they have a suspected what? Cervical spine injury. So you're going to maintain that neutral alignment to maintain their cervical spine, because that's where all of your breathing and all of your vital organ stuff, respiration drive and all of that is in your cervical. That's why that brain herniation, all your brain tissue was coming out the foraminal valley, which is right before the hypothalamus, and that's why it smushes all of that, and there goes your drive to breathe. When you have the brain herniation, that's why they're LOPA candidates. So, anyway, but we have to inspect what's underneath. If I come in and we got a collar on, what's underneath that collar that's really important? Your trachea, right. And what else? You got two of them, one on each side. Carotid arteries. Okay. Now, I know because the patient's on a monitor, I've checked my peripheral pulses, I know they got a freaking carotid. But you don't know, and this is usually, especially in motor vehicle crashes, where now they have the windshields that they just kind of all intact, but you don't know if there's shards of glass, because EMS doesn't know. They might have shards of glass in their hair that fall down, and they don't see it when they're putting the C-collar on them. So, and you lacerate your carotid, and you're gone pecan, okay? So, y'all learned before y'all learned about log rolling, right? Well, when you have to inspect, because you have to take the front of the collar off to inspect the neck as you're going down your head to toe assessment. So the person who is at the head of the bed in wherever, it's the trauma room, the ICU, or whatever, somebody has to maintain neutral alignment of the cervical spine while somebody else peels that Velcro off and opens up to inspect the trachea to make sure it's in what position? What do we want? Midline, right. Y'all didn't learn yet about the tracheal deviation yet, did you? But you will real soon. It is never good for your trachea to be deviated because that means that you got a tension pneumothorax, and that is another big problem, okay? But you'll learn about that from Ms. Dickerson. So anyway, I'm looking to see if the trachea is midline. I am also looking to see, you can't assess tracheal deviation when somebody's laying, you cannot assess for JVD when somebody is laying supine. They have to be at like a 45-degree angle, but this person is lying flat right now, so we're not assessing for JVD right now. So they put the collar back on because we've assessed the neck. We already said we're looking for the rise and fall of the chest. Even though the machine is doing the breathing, we got it set on a rate and blah, blah, blah. As we go down, what's underneath the chest? The diaphragm, and underneath the diaphragm is what do you feel every day when you eat something? Your abdomen, your belly, your intestines, your GI tract. Auscultate bowel sounds, right? That doesn't go away. And if you got no bowel sounds, or you got really, there's different things about bowel sounds that you're going to learn, especially if you work on a medical surgical floor. Your bowel sounds and the different types of bowel sounds mean something different. Or if you don't hear and their stomach is swollen and they've had some type of traumatic injury to them, it could be swollen and round and firm and distended because they're bleeding in their gut. Okay, so different things. My point is you never deviate from your full head to toe assessment on somebody no matter what the problem is. Okay? So you're going down to GI-GU. What do you think that patient's going to need related to a GI-GU? An indwelling urinary catheter because they're going to get hourly I&Os. Okay? We're going to assess our extremities. And then how did we say we're going to roll this patient? On the count of 3, 1, 2, 3, we simultaneously log roll them. Somebody's also removing the back of that C-collar to look to see if there's any spinal disformity or anything like that, anything caught up underneath there. Putting it back on, though. Doing the whole posterior assessment, and then on the count of 3, we're log rolling it back. And we're taking the board off. We're still going to keep the C-collar on, but now they do not use, for years we used the long spine boards, and we kept them on there until we got all kinds of x-rays on them. But TNCC, which is a trauma nursing core course, says now the board causes more harm than good. We'll keep them lying flat, mind you, but if they have a head injury, they'll put the whole bed in a reverse Trendelenburg so their head will be up, because what do you think lying flat does to your ICP? Increases it, exactly. So they may not be able to sit them up, but they will tilt, the beds can tilt this way and that way. You just got to make sure you got a footboard on there so they don't slide off the bed. All right. Let's see. All right, so we got our head to toe done, right? Front and back, the whole 9 yards. What kind of lab work do you think this patient's going to need? Holler it out. Don't be shy.
H and H.
What?
H and H.
Well, an H&H comes in a what?
CBC.
A CBC. Nobody escapes. A CBC. What else? CMP, probably. Not just a BMP, because we want to get some other stuff on them as well. What else? PT, what?
Maybe like CSF, like check.
Not yet. No, not yet. But what's your little blue top?
Oh, PT,
PT, PTT, INR coags. We got to know because we know that she had a history of high blood pressure and diabetes, but we didn't get no meds on her, did we? A history of any meds. She could be on a daily aspirin. She could be on who knows what. So we need to check coags, especially if we're thinking it might be some kind of head trauma inside. We're worried about somebody who's bleeding like a stuck pig, right? Because they're hypercoagulated, because high blood pressure, you don't know. She could have undiagnosed AFib. No, she wouldn't have that because she's in a sinus rhythm. But everybody and mama pretty much takes a baby aspirin. Maybe not you. I don't either. But probably a lot of other people walk around just popping one because. So anyway, you got your CBC, your CMP, your PT, PTT. They're a trauma patient. What is the most important lab you're going to get on somebody, especially if you're going to ship them to the OR? And they get a band on their wrist with it too. What's it called? Type and cross, absolutely. I can't tell you how many times patients came into the ER, they were so messed up. We did not have, if they didn't get them straight to the OR, they were going to die right there in the ER. So we got a type and cross, threw it on the bed, sent the band, threw it on the bed, and hopped them up in the express elevator to the 12th floor OR. So type and cross. If she was within childbearing years, what would be important? UPT, UA, UTOX, maybe, we don't know. What if they was drunker than a skunk and fell down, or what if they were, heroin, boom, fell down, you don't know. So a lot of times, especially if you don't know what's going on, these are just common things you're going to get. I got a bunch of time, so I want to give y'all a break. Damn, why didn't y'all tell me I was going over? Let's take you 10 minutes. We were on a roll, though, weren't we? All right, take you 10 minutes. I'm still waiting. Looks like, isn't there somebody sitting there? There's books there, so I'm assuming there's somebody sitting here. There she is. Perfect timing. Exactly 10 minutes. All right, so let's get started. So we talked about the labs. What kind of diagnostic studies is this patient going to need? What kind of x-rays? Brain and spine include, right, neck, spine, the whole spinal series. And what other kind of diagnostic tests are they going to get related to that as well? Not yet. Too expensive. What's cheaper? The CT of the head. With or without contrast, you think? Without. Right. They don't need it. Contrast is for if you're looking for masses and stuff like that. They may get a CTA, which is to look for microscopic arterial bleeds or whatever in their head. They'll do that too. But historically, it's going to be at least a CAT scan of the head and neck. They'll get spinal x-rays. Now, if they think that there's some kind of spinal injury as well because of neurodeficits down here, they'll get a CT. They'll go into the whole kit and caboodle, okay? But remember, that's x-rays, we're trying, you don't want to light them up to have them look like a Christmas tree if you don't have to. So, so we're gonna get CT and all of that. What kind of equipment? And so we already have them on a ventilator. We got them on a cardiac monitor. We already put a urinary catheter in them. We have 2 lines going on them. Y'all think of anything else we need them on? At this point, we're not in the OR, we're still in the ER. So there's not a whole heck of a lot else that we don't have. All right, now, moving on though, Miss Smith went to CT, okay? She was diagnosed with a subarachnoid hemorrhage. And they took her to the OR. And they put an intraventricular monitoring system into her. And it was, which is the drain that they put in. They drill a hole through your skull and they put a drain down into your ventricle to drain excess CSF to decrease your ICP sometimes. That's not the only thing that they can do, but that's one of the things they'll do. All right? And the goal is to maintain an ICP. What's your range? 5 to 15. What are we concerned about? What number are we concerned about if they hit and sustain it for a decent amount of time? 20. And I read in the literature, and I don't know if it got added to this. I think I did this in the fall of 23. I re-recorded this in the fall of 23. I used it, no, might have been the spring of 23. Did I say in here that I read in my new lecture, if any of y'all listened to it yet, I read recently that, because they would always say, well, how long are we supposed before we call the doctor if it's greater than 20 or whatever? I think they had said if you have it greater than like 10 minutes or longer, that is kind of a telltale that it's not going down, because it should go down after you, whatever stimulus you invoke that causes the ICP to go up, it should, once you stop it, it goes down again, okay? But the problem is, if it stays up and doesn't go down, we got a problem. We got to call, that's when you call your the healthcare provider. All right, so based on that, let's see where we got. All right, so we talked about, so she got, after surgery, she was brought to the neuro ICU, and she is your patient. The patient's airway and breathing are being maintained via the mechanical ventilation. She has a ventricular monitoring system and drainage system attached to a rolling pole. I have a picture of this thing on here. And I'll show you. All right, so this is one brand of intraventricular monitoring systems, okay? We don't set this up. Nurses, a neuro doctor will usually set that up. Not to say that a nurse can't, because they in-service the nurses in the neuro ICU on setting it up and maintaining it as well. But we're definitely not drilling a hole in their head and feeding that catheter into them. But I want to explain to you here what this is in case you don't understand what it is. All right. this is the monitor wire that's gonna go around. This is keeping it in place, and it's in your book, it'll show you the different places where they can put it, but I'm not so much worried about the placement. No matter where it is, you're still gonna monitor it, you still gotta know what's going on with it. So this is the whole CSF drainage system, and I had a video, and I didn't, I don't know if it's still good, because sometimes those links go bad, but I do have a video about one of the monitoring systems that I'll put on there, just so that for you visual people, or you can look up a monitoring system on YouTube if you want, but I'll check the link, and if the link's still good, I'll put it on there. But what I was trying to put on Canvas was kind of what you needed, and some fluff I'll throw up there later. All right? So this is your monitoring system. You would drain it by turning your stopcock. But this thing right here, this is the important thing that I want to bring to your attention. This is the transducer, okay? This is hanging, there's a string that's hanging, and you literally are hanging it off of an IV pole, all right? But this transducer is hooked up to the side of this, and there is a certain landmark on the body that this transducer needs to be in alignment with. And what is that?
The tragus of
The tragus of the ear. Okay? You know the thing some of y'all pierce? That piece of cartilage? Okay? So, because transducer, when I say the word transducer, what pops into your head? What's the purpose of a transducer? What do you think a transducer does? Transmits, exactly. It transmits information. Okay, so just like your cardiac monitor, you put your leads on it. Those leads have wires, and they're hooked up to a monitor to transmit the heart rhythm. Well, this thing here, the wire or the transmitter itself is inside, sitting in the ventricle to measure. The whole idea behind this thing is you're measuring the intracranial pressure. So you've got your whole measuring system in there, hooked up to here, and this transducer, this little wire right here is going to plug into a monitor, just like your cardiac rhythm plugs into your monitor, right? Now, anytime you have any kind of transducer like this, and you're going to learn when y'all talk, when I think it's Garrettson that teaches y'all about the arterial lines, there's a transducer along with that too that plugs in. Anytime you have a transducer like this, you're going to have to make sure it stays calibrated and it's reading correctly. So there's a term that it's called zeroing a monitor, just like when you're sort of like zeroing out. Huh?
Scale, like weight, you have to zero it out.
Yeah, exactly. The same idea. But every time, like this is hooked up to a monitor, but if the patient has to go to CAT scan, and they go to CAT scans often, there's usually not. You can take a portable cardiac monitor. You can take a portable vent, but there's not too many portable ventricular. You're going to take this contraption, that rolls with them wherever they go because it's stuck inside their head. But the monitoring of the ICP, they will historically unplug that portion of the monitor, take the patient to CAT scan. When they bring them back and they plug it in, they have to make sure this is lined up with the tragus, and then they've got to zero the monitor to recalibrate it to make sure it's reading the ICP correctly, okay? So the main thing that you want to understand is alignment, because like with the arterial line, in order for it to read accurately, that transducer needs to be at the phlebostatic axis. She's going to talk to you about that. And So there's a bunch of different monitoring going on. And remember when y'all were being tortured about learning landmarks for bones and this, that, and the other in AMP1? Well, there was a reason for that. Because these same landmarks, you could, just like you have to have your landmarks to give your injections accurately, there are certain pieces of equipment that line up with certain anatomy. Okay, so that's the reason why y'all have to go through all of this. All right. So, I already talked about that. So let's move on to. All right. Y'all got the gist? All right, so before I move on, I already said there is a hole drilled through your skull. Any hole or anything that God didn't make on your body, that humans make on your body, is a portal of entry for what? Infection, microbes, okay? So that's why there's a clear plastic dressing that goes over to keep it clean. Most of the time they're like, oh, clean your dressing, change your dressing, blah, blah, blah. Well, now the literature is saying if it ain't broke, don't fix it. You're going to have a little bit of blood, just like when you put in a PICC line or a midline or any kind of like that. Y'all have all seen midlines or PICCs at some point in time. They will put the dressing, that gunk, jelly, they put on, they don't clean anything off. They leave it there because that's your blood, okay? Hopefully they cleaned it really well before they stuck you. And they put that jelly junk that's really hard to get off, but it seals. And that's the same thing that we call them a trade name for things. So like opsites, the clear occlusive dressing, they're putting that to cover up everything but the hole, all right? So literature says, don't change that thing unless it gets really funky. Bottom line, okay? Because the more you fiddle with something, the more you change it and mess with it, the more at risk you are of breaking some kind of sterility or introducing microbes, okay? So that was my main thing that I kind of wanted to get across to you, because this person, you got a hole in your head. What are you at risk specifically, and y'all learn this in peds? What did you say? Meningitis. Absolutely. Okay. So this person is at risk for developing meningitis. Anybody with any kind of hole in their head or whatever, meningitis. All right. So you want to make sure that you're watching them. Hourly assessments minimum. But again, you got to pay attention. You get your baseline on your patient at the beginning of your shift or when you receive them. And then if they're hourly neuro, you got to pay attention. Because now this thing will read off your intracranial pressure readings. So you can see that number going up and down. But as far as, and if that goes up, there's a problem. But there's other parts of the neuro assessment that you have to do that have no monitor to them. That's you and your skills of checking and assessing, okay? So, again, like I told you, if you're going into an area where pupillary responses is something you're going to be doing all day long, then you got to practice that skill over and over, and you can practice that at the house with your pen light in a dark room, just shining it and watching yourselves going. You'll learn it after a while, okay? You got to pay attention also with if they had any type of movement, because just because they're sedated, unless they're paralyzed and sedated, and sometimes they will initially sedate as well as paralyzing because moving around and everything, a severely agitated individual, what does that do to your ICP? It increases it, okay? Another thing also, the patient's going to be in the ICU. Now, I know Ms. Garrison told y'all family presence is very important, and it is, okay? However, you have to watch your patient, and if your family is at the bedside and you see that their ICP, because you don't know what's going to increase somebody's ICP. Everybody is different. It could be regular tone of voice. It could be tactile stimuli, just touching them. You don't know. But you got to pay attention to what the stimulus is that's causing the ICP to go up, and that you got to get rid of that stimulus. And if that stimulus is talking, continuous talking, you have to let the family know. Since y'all have been in here talking to the patient or talking amongst yourselves, even if they are whispering, I've watched their ICP go up. So what I need to do now is I'm going to ask y'all have been here for a little while, I'm going to ask y'all to go get something to eat, go get something to drink, because they got to have a brain rest, because I know you want them to be well. And it's not you personally. It's just any kind of noise seems to be getting them agitated. So let's give them a break. There's a way to talk to people. Y'all know that, right? And then have them come back. These patients, if they are that sensitive, and we don't know until we get them, and everybody's different, you are going to have to do things to them that are going to increase their ICP because they're on a ventilator. So what are you going to have to do periodically? Suction. Y'all had to check. I know y'all had to check off because I did it with some of y'all already with the ET tube. In and out in 10 seconds because that whole in and out thing, that agitation is increasing their ICP. And it's cutting that down on their O2. And they already, having problems. So we don't need to add insult to injury. Loud talking at the nurse's station. Lights. Ventilators. Noises going off. Monitors going off. You can't turn them on silent because there's a reason for it. But you got to, as the nurse, address it as soon as it happens, Every time, it'll become automatic. They talk about alarm fatigue, but I never had alarm fatigue because my head automatically went, and I looked at my monitor, I looked at my vent, I just automatic. Did you know? You were in the unit. Didn't you work in the unit, Ms. Bezos?
Yeah.
Right, so was it not an automatic response? And then your brain registers, oh, good numbers, or oh, okay, all right, they just moved, or something like that. So those are going to be like automatic responses to y'all. So that's a good thing because they need to be. So hopefully y'all never experience alarm fatigue. So another thing is, let me go back up here just to make sure. We already talked about all that. Oh, Glasgow Coma Scale. Y'all gotta know how to calculate a Glasgow Coma Scale score. If I give you this is what's going on with them, and you get, I'm not gonna make you memorize the chart. That's crazy. Nobody expects you to memorize it. But if you get the chart given to you, and I give you a scenario, you gotta recognize what each one of them means and give me a score. Okay? Cerebral perfusion pressure. What is normal cerebral perfusion the range? It's on your maintenance algorithm thing.
60 to 65.
It's 50 to 70. I will tell you that most of your now I'm keeping you to these numbers because I'm giving them to you. I'm telling you, though, that a lot of them are more narrow in practice. 60 to 70. What's your normal MAP range? 70 to 100. From now until you get out of school, every time you see a blood pressure, you calculate a MAP. I promise you, you will be calculating MAPs all day tomorrow. And if you're one of these people that writes really big and you only get one piece of scratch paper, write smaller. Or bring an eraser, one of the two, okay? Because you need to calculate your MAPs. And if your MAP is less than 70 or above 100, you're probably going to do something about it, okay? So, we have to give y'all ranges for labs. We do not have to give you ranges for MAP, ICP, CPP, or anything like that. It's only lab ranges. Keep that in mind. We don't have to give y'all formulas either, because NCLEX doesn't give you formulas either. So, how do you calculate? First of all, what does CPP stand for? Cerebral perfusion pressure. So if you take each one of those words, cerebral head perfusion blood pressure, you can kind of figure out what, the purpose of it. What is the formula to calculate the cerebral perfusion pressure? It's MAP minus ICP. So, I could easily give you a question that says, your patient has a blood pressure of this. I will give you the ICP, because you can't look at anybody and say, your ICP is 15. No. They gotta have the monitoring system on them. So I could easily give y'all, I got a lot of test questions I can ask related to this stuff that are really easy for me to fool with. So I can give you a patient's got a blood pressure of this, their ICP is this, what's their CPP? Because that's one of them alternate format questions that I love to write. Okay? I talked to you about that. That bundle that Ms. Garrettson already talked to y'all about. It's the same thing. The only thing I didn't talk about was exposure and environment, and what that means in the world of trauma is I've already assessed your airway, breathing, circulation, and neurodisabilities. Then I've got to strip you buck naked, because me, the trauma nurse, needs to inspect you anteriorly and posterior for any other potential visible trauma. So I expose you, but what does shivering and being cold do to your ICP? So I've got to do it in a systematic, short time frame, because you're shivering, and so I've got to cover you up with warm blankets afterwards, because all of the trauma resuscitation rooms in the ER, just like every place else in the hospital, are historically cold. Okay? So, this is something you already know, folks. There's your Glasgow Coma Scale, there's your C-collar, neurosurgical interventions. I already told y'all this one went. They have the subarachnoid, they needed to measure the ICP, so they went and took them to surgery. Some will evacuate blood. This is another way to evacuate blood and CSF to bring your ICP down, because the brain tissue is very irritated when blood, you got that already, just FYI. You got the whole thing on your recording. Because this is the PowerPoint from the voiceover recording that I do for you.
I don't remember seeing that one in that slide in the recording.
Okay, well, I'm pretty sure it's in there. Okay, all right, so it is, so you didn't miss it. Anyway, so, let's see. Let me move on to the next one to make sure. All right, care for the patient with increased ICP. That's the secondary injury. The big secondary injury that's going to do them in, that you're going to have to continuously monitor for and correct. Assess for cues indicating metabolic complications as well. What type of metabolic state is somebody going to be in when they've sustained major trauma? Low metabolic state or high metabolic state? High. Why? What is your metabolism doing when you're working out? It increases because it's trying to keep up with the demands of the energy that you're expending. Okay? Trauma does the same thing. Okay? Your body wants to maintain homeostasis even against the pressure of running or brain trauma or any kind of trauma for that matter. All right? So you're going to be in a hypermetabolic state. Fever or shivering, again, all of that. Fever puts you in a hypermetabolic state as well. So, dietary concerns. Let me go to... Where'd it go? Hold on. Here we go. All right. If you look at this and you use this as your guide, we've talked about a lot of things already. So, ICP and CCP management. Okay, CPP management. We're managing ICP and CPP through measuring with the ICP, the ventriculostomy shunt, the whole 9 yards. That's monitoring. Maintain ICP less than 20. We want normal 5 to 15. It will go up when we suction them. It will go up when we have to stick them. It will go up when we have to turn them and check their backside or clean them. Luckily, we have catheters. We have the PureWicks now, all of that stuff, but people still poop. And those bad poop things, they're a mess. I mean, when they work well, but a lot of times they don't, and it's more of a mess. So let's see. Sometimes we're going to have, because you're going to have to assess their neck and all that stuff every time. And patients with head trauma may keep those collars on for a while. And you're going to have to assess them. And then you're going to have to put them back on again. If you assess, you're doing the whole thing, somebody's got to get here, somebody's got to maintain all of the stabilization, somebody's got to open it, and then somebody's got to put it back. And 9 times out of 10, it's a Velcro fastener. You don't know how. There's a fine line between fastening it securely and fastening it too tight. So if you fastened it and during your assessment, and then your patient, you're finished assessing them, but their ICP is still hovering a little high, you're like, first thing you should do is, maybe I got the collar on. Don't take it off, obviously, but let me loosen the Velcro and put it on securely, but not as tight as I might have. That's a big one that always happens. Drain CSF, sedation, elevate the head of bed to 30 degrees. You don't want to lay them flat, and you don't want to put them at a 90-degree angle, because raising their head up too much increases ICP as well, okay? So positioning is important. Giving mannitol, initiating insulin therapy, or promoting normothermia. We already said you don't want them too hot, you don't want them too cold, you want them just right. Blood sugar levels. Trauma, what do you think trauma does to your glucose levels? Increases it, you're right. But what does increased glucose levels do to wound healing? Slows it down. So there's a fine line we got to maintain. So that's why you'll see patients who are sick in the hospital on sliding scale insulin. They don't have diabetes, but because they have an infectious or inflammatory process going on, their blood sugar is going up, or they're on steroids for something, and we got to maintain that in order for them to heal. Okay? Let's see. Hypertonic saline and mannitol. Those are 2 of the things that we can do to decrease their ICP. Okay? Mannitol is an osmotic diuretic. So remember that shifting from a level of concentration to the lower, remember y'all learned that? That's what mannitol does. Hypertonic saline works the same way, but you gotta remember, normal saline is 0.9% sodium chloride. Hypertonic is a lot of salt. 3% to 24%. Those are drugs, folks. Those are lethal drugs that you may give in boluses, but I'm not talking about a liter wide open. I'm talking about like cc's of it. But anytime they give you something at one time, they technically call it a bolus, okay? But these are people that'll kill you, okay, if you do it wrong. Centraline or PICC line is the standard of care for hypertonic saline. So if they come in and all they got is peripherals and they ask you to order that, say, where's my Centraline? I need it because it's so caustic to veins, okay? Adequate nutrition. I already told y'all about wound healing and all of that. So nutrition. What are the 3 categories that we balance to keep balanced nutrition? What are they? Protein, carbs, and fats. There is a balance that you must maintain. For wound healing, you want them to have adequate protein. To give them fuel, adequate carbs, which we all love. And there is a reason to have fat. But it is a balance. I'll teach burns. I'll talk to y'all more about that. But dietary considerations must be within, what do they say, 72 hours. It's up to you as a nurse to remind your healthcare providers, hey, it's been 72 hours. They've been NPO. They got this OG tube. I'm giving them the PPI to make sure that they don't develop these gastric ulcers, the stress ulcers. But we got to get some nutrition on board some way or another, okay? Because that promotes wound healing. Normal glycemia, seizure precautions. Y'all learned about seizures. Whether it's epilepsy or not, seizures are seizures are seizures. What are the drugs that we give patients for seizures? I heard, what's the trade name for the one? Levetiracetam. It took me forever. Now I can spit it out. I can't spell it, but I can, and I'm not going to ask you to spell it either. But it's the generic name for Keppra. Just gave it yesterday. I take my students to the stroke unit at East Jefferson, and we got a brand new neuro ICU right next door, so we'll get them when they come out of there. We give IV Keppra all day long, okay? It comes in an oral form as well. So I want you to understand about the mannitol and how it works. Y'all learned that in pharmacology hopefully already. That is one treatment modality to decrease your ICP. Giving them hypertonic saline is another modality. Patients with head trauma are at risk for developing seizures, so they will cover them with some type of seizure medication, and that could be a lifelong thing for them. And then what really sucks about that is that if you're at risk for seizures, what can't you do? You can't drive. You can't operate heavy machinery. You're not supposed to swim. You're not supposed to take a bath. So there goes some people's livelihood. Or, I don't take a lot of baths because my showers are quicker, but I'd be some upset if I couldn't, if I had one of the big old garden tubs or whatever that I could soak in. Or swim. I do enjoy swimming. So what else on here do I need to make sure that I cover in the last 4 minutes? I've pretty much covered everything, but let me go back. I'm sliding around. That's why I like working in the ER, because I don't work there anymore because I teach 2 clinicals and I ain't got time for that anymore. But I still got my friends that work in the ER, and they still have their stools they roll around with.
DBT,
What, baby?
DBT.
Oh, I'm sorry. So, that is a core measure for Joint Commission. No matter whether you're on a medical surgical floor or an ICU, what does everybody get a shot of? Enoxaparin. It's weight dependent, it's supposed to be, okay? Given in the belly fat, unless you've got a ascites or you're a taut pregnant woman or something, then it can be given. You call your pharmacy and find out where. Did y'all know that? So anybody who's been giving Lovenox as a practitioner anywhere but the belly is not, because the manufacturer says the absorption rate is better through abdominal tissue. So you go giving something in the wrong spot, and they develop a cellulitis. That's your. Yes, indeed. So you got to know, folks, every day that you go to work, the most dangerous thing that you do is prepare and administer drugs. You could kill somebody, and we all have heard of people being killed from drugs by nurses. All right? And now that lady got her license taken away, game on. Okay? So you have to be on your game, and as a new nurse, going into wherever you go, work, whether it's at ICU, med-surg, or whatever, you don't know a lot. No offense, but you don't. But y'all know you don't. But you know what you don't know, and you better know to start asking legitimate sources questions. Don't ask the new nurse you work with, okay, because that's the blind leading the blind. You need to go and talk to somebody who has, and if they tell you and it seems funky, go to somebody else, because not everybody's right, okay? You have to look at your resources. Lexicomp is real easy to use. It's on I know for Epic at LCMC facilities, boom, Lexicomp is right there. It's a wonderful, beautiful thing. And if they provide that to you as a resource, you follow it. You can always call your pharmacy. In fact, it's expected you call your pharmacy if you got any kind of a question on preparation or administration of a drug. Don't talk to the pharmacy tech. Get the real pharmacist on the phone, okay? All right. I think I pretty much covered everything that I need to with y'all. Anything that's on this video, anything that's come out of my mouth, anything that I'm asking you to read is fair game. Don't ask me, well, for testing purposes, anything I tell you or you got to read is testable material. I wouldn't waste my time otherwise. Okay? So, understand, use the discussion board for clarification on anything, but it's up to you to listen to the video, read what I tell you to read, and you should be fine. All right? Thank you for your attention. Good luck on your test. Do not change your answers. And bring your earplugs. And read the question until the end. That's what kills y'all. That's what makes you choose the wrong answers. You're shaking your head, yeah, because you've done it, haven't you? Exactly. We've all been to school, so good luck. Get to the test. Please don't run in and or don't be late, because that's just rude to the poor people who are already sitting there, and it's very distracting. But please make sure that you get to your test on time. Eat something. Your brain likes glucose and oxygen. So breathe and eat something. And good luck. Thank you for your attention. All right, y'all have it. I'll see some of y'all tomorrow.
Have a good day. Thank you.
Y'all too. Have a good morning, Grom. Oh, you're welcome. Oh, not a problem, honey. You dropping that group?
Yes.
I got to stay in my group. In fact, wait, you have, where do you go?
For Paquina,
Yeah.
I went there. We end up